Good evening. My name is Octavio Garaycochea. I'm a senior resident of ENT at the University Clinic of Navarra in Pamplona, Spain. And in this opportunity, would like to share with you this oral communication that is one of the research projects that we're doing in our voice lab. And the title is Proposal of a new, for a new classification for the diagnosis and follow-up of muscle tension dysphonia. This is the index of the presentation that I'm going to share with you. So, introduction. MTD, or muscle tension dysphonia, was first described in Morrison in 1983. It's considered a functional voice disorder that is characterized by the excessive tension of the extralaryngeal muscles during phonation in the absence of a neurological or organic disease. It's important to highlight that this disorder accounts between the 10 and 40% of all the clinical caseloads at a voice clinic. And how the diagnosis for MTD is made? Well, basically, as any other voice disorder, it's done through a comprehensive assessment based in three main components: the patient history, the physical examination, which is basically the physiolaryngoscopy and hysteroscopy, and the voice, speech, and language evaluation. In some institutions also, the instrumental assessment can be also helpful, like the radiology, electromyography, but also acoustic and aerodynamics. The aerodynamic assessment of the voice is going to give us values such as subglottic pressure, transglottic flow, or laryngeal resistance. All of them are very useful for diagnosis of MTD. But in most of hospital centers, the diagnosis will basically be done through patient history, physical examination, and the voice, speech, and language evaluation. So physical examination in basically fibrolaryngoscopy are very useful for diagnosis of MTD. But how is the diagnosis of MTD made through fibrolaryngoscopy? Well, to today, there are three main classification systems that have been described for the diagnosis or follow-up of patients with MTD. The first one was described in 86 by Ramach and Morrison. The second one was described in 87 by Van Lawrence. The last one was described in 91 by Jamie Kaufman. But the thing is, there's no international consensus of which classification systems should we use for the diagnosis or follow-up of the patients. All of the three classification systems previously described, they're all based in clinical history, perceptual acoustic assessments, voice-related musculoskeletal features, psychological evaluation, but none of them were based on objective measures, and there are like multiple terms that might be confusing, or the same clinical pattern is referred to a different name in a different classification. So at the end, it might be a little bit confusing. In a previous study that realized in our voice lab, we studied the three classification systems and we analyzed them. We related them to two abnormal aerodynamic studies, and we arrived to the conclusion that the clinical feature that were more related to an abnormal aerodynamic study assessment was the ventricular fold contribution to phonation, the anterior-posterior compression of the larynx, and the lateral compression of the larynx. So based with this information, what we decided to do was to propose a new classification that it's actually based in the three previous classifications, but it's only using, it will only use the clinical features that are more related to MTD, and they are more related also to an abnormal aerodynamic voice assessment. Material and method. So we perform a prospective cross-sectional study which we include 37 consecutive patients with MTD, all of them with altered aerodynamic profile. All of them had more than 90 mmHg of subglottic pressure. We exclude patients with underlying structural abnormalities, including those abnormalities related to glottal insufficiency, or we exclude also patients with neurological abnormalities or acute medical conditions such as upper airway infections. So regarding clinical features, as primary features, we assess the supraglottic anterior-posterior and lateral compression, and as a secondary feature, we also assess the posterior glottal gap. So with the hypothesis that a major grade of supraglottic compression might be related with a higher level of subglottic pressure, we divide the anterior-posterior compression in three different grades: grade 1, grade 2, and grade 3. Grade 1 was divided in grade 1A and grade 1B. Grade 1A, we cannot see the commissary anterior during the phonation because of the contraction, anterior-posterior contraction. Grade 1B, we cannot see the vocal process due to the rotation of the arytenoids during the speech task. In grade 2, we only see 2/3 of the vocal cord, and in grade 3, we see less than 1/3 of the And regarding lateral compression, grade 1, we're not allowed to see the laryngeal ventricles. In grade 2, we see that the ventricular folds are contact with each other at some point or during some point of the speech task. And in grade 3, the ventricular folds are in contact with each other constantly during all the speech task. This is how we perform the aerodynamic voice assessment, the acoustic voice assessment, and for the voice-related quality of life, we use the voice handicap index. So what we wanted to do at the end was measure the relationship between the compression grade of anterior, posterior, and lateral compression with the voice handicap index and the subglottic pressure value. So what were the results? The mean age of the patient was 50 years, so there was no difference in the subglottic pressure value in relation to the gender and age. In this table, we see all the results of the aerodynamic voice assessments. We see the subglottic pressure was 111.03. Those are the results of the acoustic voice assessment, also the voice handicap index. We see the mean of the voice handicap index is 27.8. So regarding AP compression was present in 34 patients at the 91.8%. The grade of AP compression was correlated with the subglottic pressure value. There was no correlation between the voice handicap index and the AP compression. So this is important here that we see we got a statistically significant difference in the subglottic pressure value for the different grades of AP compression. We didn't have any statistically significant difference regarding the voice handicap index in the 3 different grades. Regarding lateral compression, the lateral compression was present in 25 patients. The grade of lateral compression was not associated with a higher subglottic value, with a high value of subglottic pressure. There was no correlation between the voice handicap index and the lateral compression. So we see here there was no statistically significant difference between the 3 grades of lateral compression. We also analyzed posterior glottal gap. This feature was present in only 12 patients. It was not related to voice handicap index and neither subglottic pressure. All the voice handicap index scores for the patients were high enough to reflect the existence of a voice disorder, and the voice handicap score was not related to subglottic pressure value. So what are the conclusions we got from this study? Well, the first one is the AP compression is more frequent than lateral compression in patients with MTD. AP compression is related to the subglottic pressure value, and the higher the grade of AP compression, the higher the value of subglottic pressure. It's important. And lateral compression is not related to the subglottic pressure. So with this information, we propose this 3 classification, AP1, AP2, then this is AP3 here in the corner. So AP1 will be related with less subglottic pressure value than AP2 and AP3. But in order to have more information about what's going on in the larynx during the phonation, the different grades of anterior posterior compression that those are giving us the severity can be accompanied with a different letter L1, L2, L3 if we have some sort of lateral compression also, or PGG, that's posterior glottal gap, if we have the present also posterior glottal gap. This is important because those letters might give us more information of what's going on with the larynx. So we're not only just assessing anterior posterior or lateral or posterior glottal gap. So we can create like a formula that is going to give us more information of what's going on in the larynx during the phonation, based on the different grades of anterior posterior compression that they're going to give us the severity. So what are the benefits of this classification? Well, it's easy to use and to interpret. It's helpful in grading the severity. It's helpful for the evolution and follow-up of the patients. And also it provides a way to assemble all the pertinent laryngoscopic findings. So we're not only just using one, we're just describing all what's going on in the larynx. Well, thanks for your attention.